Look at your last blood pressure reading, not the top number, the one everyone stares at. Look at the second number, the smaller one sitting quietly underneath it. If you're over 60, that second number may be trying to tell you something your last 3 doctor's visits never mentioned. I'm Dr. David, and for years I've watched people over 60 walk out of appointments feeling completely reassured, holding onto the words, "Your pressure looks good," when the number that actually deserved attention was sitting right there on the page, unremarked on, unexplained, and quietly moving in a direction that matters. Today I want to change that for you in about 20 minutes using plain language, real physiology, and a handful of simple actions you can start tonight. Here's what we're going to cover, because I think you deserve to know exactly where this is going before we get into it. First, I'm going to explain what that bottom number actually measures and why, after the age of 60, it starts behaving completely differently than it did when you were 40. Second, I'll walk you through why a low reading on that bottom number can, in an older adult, be just as concerning as a high one, which sounds backwards until you understand the mechanism. Third, I'll give you a simple way to track this at home using equipment that costs less than a nice dinner out. Fourth, we'll talk about the specific groups of people for whom the usual blood pressure targets simply don't apply and why. And fifth, I'll give you the exact questions to bring to your next appointment so that the conversation moves past everything looks fine and into the details that actually protect you. Let's start with the basic anatomy of a blood pressure reading, because most people have never actually had it explained to them, even though they've had this number checked at nearly every doctor's visit of their adult life. When your heart beats, it squeezes and forces blood out into your arteries. That squeeze creates a surge of pressure, and that surge is your top number, the systolic pressure. Then, between beats, the heart relaxes and fills back up with blood before the next contraction. During that relaxation phase, the pressure in your arteries drops to its lowest point, and that lowest point is your bottom number, the diastolic pressure. For most of the 20th century, and for a huge portion of medical training even today, diastolic pressure was treated as the more important of the two numbers, especially in midlife. That emphasis came largely from long-running population studies that followed thousands of adults over decades, watching who developed heart disease and who didn't. In middle-aged adults, a persistently elevated diastolic number turned out to be a genuinely strong predictor of future cardiovascular trouble. Generations of doctors were trained on that finding, and it shaped how blood pressure has been talked about in exam rooms for 50 years. But here's the part that rarely gets explained to patients. What's true at 45 is not automatically true at 70. Your arteries are not static pipes. They change as you age, and the way they change flips the meaning of that bottom number almost completely. Picture a young, healthy artery. It behaves something like a length of surgical tubing, elastic and springy. When the heart pushes blood into it, it stretches slightly to absorb that pressure, and then, critically, it recoils. That recoil pushes blood forward and helps maintain pressure during the resting phase between heartbeats. This is sometimes described as the artery acting like a second pump, smoothing out the pressure wave and keeping blood moving steadily even when the heart itself is between contractions. Now picture that same artery 40 years later. Over decades, the elastic fibers in the arterial wall, particularly in the aorta, the large vessel coming directly off the heart, gradually break down. They're replaced by stiffer material, and in many people, small deposits of calcium accumulate in the vessel wall as well. The result is an artery that has lost much of its stretch and recoil. Instead of behaving like elastic tubing, it starts to behave more like a length of rigid pipe. That change has two consequences, and they happen at the same time, which is exactly why doctors care so much about the relationship between the two numbers, not just each one in isolation. Because the stiffened artery can no longer absorb and cushion the force of each heartbeat the way a flexible one could. The systolic pressure, the top number, tends to rise. And because that same artery has lost its ability to maintain pressure through recoil during the resting phase, the diastolic pressure, the bottom number, tends to fall. Your top number climbs, your bottom number sinks, and the gap between them widens. That gap has a name. It's called pulse pressure, and it's simply your systolic number minus your diastolic number. If your reading is 150 over 70, your pulse pressure is 80. If it's 130 over 80, your pulse pressure is 50. On its own, pulse pressure rarely gets mentioned to patients, but among cardiologists, it's considered one of the more telling markers of arterial stiffness available from a simple cuff reading. A wide pulse pressure in someone over 60 isn't a quirky number. It's the artery essentially reporting its own age and condition back to you. Now let's talk about why the low end of that bottom number deserves just as much attention as the high end, because this is the piece that trips people up, including, frankly, some well-intentioned health articles that try to simplify this topic and end up flattening an important nuance. Here's something most people have never been told. Your heart muscle does not receive its own blood supply during the contraction phase. It receives it during the relaxation phase, the same diastolic phase we've been discussing. Every other organ in your body gets fed continuously. but the heart's own coronary arteries are actually squeezed shut when the heart muscle contracts around them. The heart has to wait for its own resting phase to feed itself. This means the diastolic pressure isn't just a number reflecting arterial stiffness. It's the actual driving pressure behind the blood flow that keeps your heart muscle, and by extension, a great deal of blood flow to your brain, adequately supplied. If that resting pressure drops too low, particularly in someone whose arteries have already stiffened with age, the margin for adequate blood flow to the heart and brain can become uncomfortably thin. Researchers describe this relationship using something called a J-curve. Picture a graph where cardiovascular risk is plotted against diastolic pressure. As diastolic pressure comes down from a genuinely elevated level, risk falls, which is exactly what you'd expect and exactly why blood pressure medications exist. But the curve doesn't keep falling forever. At a certain point, usually somewhere in the range below 60 for many older adults, the curve bends and starts climbing again. Push the number down too far, and risk rises once more, not because low pressure itself is dangerous in a healthy young artery, but because in a stiffened, aged artery, that low pressure translates into inadequate blood flow to organs that can't tolerate being shortchanged. This is genuinely counterintuitive if you've spent decades hearing that lower blood pressure is always the goal. For a large portion of your life, that was broadly true. After 60, particularly if your arteries show signs of stiffening, the relationship becomes more nuanced, and lower stops being a universal virtue. This is exactly why a diastolic reading, sitting comfortably at 56 or 58, can look at a glance like a mild success rather than a warning sign. A number in the 50s doesn't trigger the alarm bells that a high number does. There's no flashing red text on the printout. The medical assistant doesn't pause. The room doesn't tense up. And yet, in a 70-year-old with stiffened arteries, that same number can indicate that the heart and brain are being asked to function on a margin that's thinner than it should be. I want to be careful here, because this is exactly the point where oversimplified advice tends to go wrong in the other direction too. Some health content will tell you flatly that a low diastolic number is nothing to worry about after a certain age, full stop, because only the top number matters as arteries stiffen. That advice isn't entirely false, but it's dangerously incomplete, because it erases the difference between individuals. In a genuinely healthy 50-year-old with elastic, well-functioning arteries, a relaxed, lower diastolic number really can just reflect easy, efficient circulation. That same 56 or 58 would be nothing to lose sleep over. But drop that identical number into a 70-year-old with a stiffened aorta, and it can mean something very different. Same number, different artery, different meaning entirely. Advice that treats every low diastolic the same way, regardless of age and arterial condition, ends up reassuring exactly the people who most need to ask a follow-up question. So how do you actually use this information without becoming anxious every time you glance at a home monitor? This is where I want to give you something practical, because understanding the physiology is only useful if you can translate it into action. The first step is getting yourself a proper way to measure blood pressure at home, because a once-a-year office reading, taken on a day when you might be rushed, mildly anxious about the appointment itself, or sitting in an uncomfortable position, simply cannot capture what's happening to your numbers over time. You want an upper arm cuff, not a wrist device. Wrist monitors are convenient, but they're considerably less reliable, partly because the arteries at the wrist are smaller and more sensitive to positioning. And even a slightly wrong wrist angle relative to your heart can throw the reading off by a meaningful amount. A good automatic upper arm cuff typically costs somewhere between $30 and $50 at most pharmacies, and it's one of the more useful health purchases you can make in your 60s or 70s. Before you buy, look for the word validated on the packaging or the manufacturer's website, which means the device has been tested against accuracy standards used by cardiology organizations. There are independent, publicly available listings online that track which specific models have passed this kind of testing, and it's worth a few minutes to check before you commit to a particular device. Cuff size matters more than people expect. A cuff that's too small for your upper arm will tend to read artificially high, while one that's too large will read artificially low, and the gap this creates can be more than 10 points in either direction. Most devices come with sizing guidance, and many pharmacies sell a couple of size options, so it's worth measuring your arm circumference before you buy rather than guessing. Once you have a proper monitor, the way you take the reading matters just as much as the device itself, and this is where I see people accidentally sabotage their own data without realizing it. Sit quietly for a full 5 minutes before measuring, not 1 or 2. Because it genuinely takes that long for the small physiological noise of getting settled, moving around, maybe climbing stairs or having a brief conversation, to fade out of your circulation. Keep your feet flat on the floor rather than crossed. Since crossing your legs alone can nudge the reading upward by several points, make sure your back is supported, because if you're perched somewhere without support, The effort of holding yourself upright tenses muscles in a way that subtly raises the number. Rest your arm on a table or armrest so that the cuff sits roughly level with your heart, not hanging down at your side and not raised above shoulder height. An arm that's dangling below heart level can inflate your reading by up to about 10 points, essentially because you're partly measuring the added weight of the blood column rather than the pressure inside the vessel alone. Stay quiet during the actual measurement, since talking can raise a reading noticeably too, and try to avoid measuring right after coffee, exercise, or if you've just rushed to the bathroom, since a full bladder alone can lift the number slightly. Take 2 readings, about a minute apart, first thing in the morning before you've taken any medication or eaten anything, and write both numbers down, top and bottom, every single day for around 2 weeks. This isn't about creating anxiety through obsessive tracking. It's about generating exactly the kind of trend data that a single annual office visit can never give you. After those 2 weeks, do 2 simple things with your numbers. First, calculate your average pulse pressure by subtracting your typical bottom number from your typical top number. In an adult over 60, a pulse pressure that consistently sits above 60 is worth a genuine conversation with your physician, and above 70 deserves a more urgent one. Second, look at your bottom number in isolation, separate from the top number entirely. Is it consistently sitting below 60? Or, just as importantly, has it been quietly climbing over recent months, even if each individual reading looked unremarkable on its own? A diastolic number that creeps upward over time, say from the low 70s into the high 70s or low 80s across a period of months, can be an early signal of rising resistance in the smaller blood vessels, a signal that would be completely invisible to anyone looking at a single yearly snapshot, but which becomes obvious once you're watching the trend rather than the moment. This distinction between a snapshot and a trend is, in my view, one of the most underappreciated ideas in everyday cardiovascular health. A single reading tells you almost nothing about direction. A pattern over weeks or months tells you a great deal. 2 people can both walk into an office with identical readings on a given day, and one of them is stable, while the other is in the middle of a steady climb that simply hasn't been visible yet, because nobody has been watching the line connect the dots. Once you have this information, bring it to your next appointment, not as a source of anxiety, but as data. Print out your 2-week log if you can, because a physical printed record changes the nature of the conversation in a way that simply describing your concern out loud rarely does. It turns a vague worry into a data set that's difficult to wave away with a reassuring but generic comment. A 2-week morning record, taken under consistent, controlled conditions, genuinely provides more useful information than the single rushed reading an office visit typically captures. And most physicians will recognize that immediately when it's placed in front of them. Along with that log, I'd suggest asking 3 specific questions, because each one is designed to force a concrete answer rather than a reassuring generality. Ask what diastolic range is actually being targeted for you personally, given your age and health history, and whether that target reflects current guidance rather than an older, more generic rule of thumb. Ask directly whether your pulse pressure falls into a range that's a source of concern. And ask whether any of your current medications, particularly if you're taking more than one blood pressure medication, could be contributing to your diastolic number running lower than intended. Each of these questions requires an actual number or an actual clinical judgment in response. This brings us to something that deserves real emphasis. Blood pressure targets are not one-size-fits-all, and there are specific groups of people for whom the standard advice genuinely doesn't apply in the way it's usually presented. The first group is adults over roughly 75 with meaningfully stiffened arteries, where pushing the diastolic number aggressively low can cause more harm than benefit, precisely because of the J-curve relationship we discussed earlier. In this group, the goal generally isn't the lowest possible number, it's the right balance for that individual's arterial condition. The second group includes people living with diabetes or existing kidney disease. These conditions often mean the smaller blood vessels throughout the body are already under some degree of strain, and an aggressively low diastolic pressure can push an organ system that's already operating close to its margin into genuine trouble. For this group, an individualized target, set in conversation with a physician who understands the full picture, tends to matter more than a generic number pulled from a textbook. The third group is anyone taking multiple blood pressure medications at once. 2 or 3 medications, each individually reasonable, can combine to pull the diastolic number down further than any single prescriber intended, especially if different specialists are each adjusting one piece of the puzzle without a complete view of the others. This is a genuinely common and often overlooked scenario, and it's precisely why the question about medication timing and combination is worth asking directly rather than assuming someone else has already checked. It's also worth knowing that the major cardiology and hypertension guidelines have shifted over the past several years, moving away from a rigid, one-size-fits-all approach toward more individualized targets that account for age, frailty, and coexisting conditions. Despite that shift in the guidelines themselves, many everyday appointments still run on an older reflex, the assumption that lower is categorically better, regardless of context. For the groups I just described, that assumption doesn't hold, and it's worth advocating for a more individualized conversation if you fall into one of them. There's one more piece of this that even a thorough appointment can sometimes miss entirely, and it involves what happens to your blood pressure while you're asleep. Most people experience a natural dip in blood pressure overnight, typically somewhere in the range of 10 to 20% lower than daytime levels, as the body shifts into a lower demand resting state. For most people, this is completely normal and healthy. But if your daytime diastolic number is already sitting close to 60, that normal overnight dip can carry it into the low 50s, or occasionally lower, during the deepest hours of sleep, precisely the hours when you're least likely to notice any symptoms and when no office visit or morning reading will ever capture what's happening. A 24-hour ambulatory blood pressure monitor, a portable cuff worn for a full day and night that takes automatic readings every 20 to 30 minutes, is the tool designed specifically to catch this pattern. If your numbers throughout the day are comfortably within a normal range, this generally isn't something you need to pursue. But if your daytime diastolic tends to run low, asking your physician about a 24-hour monitor is a reasonable and informed question, not an overreaction. I want to be clear that this is informational context, not a prescription for anyone specifically, and any decision about medication timing or dosage needs to be made directly with your own physician, who has the full picture of your health history. I think it's worth stepping back for a moment and talking about why this particular number, the diastolic pressure, matters so specifically for stroke risk in people over 60, because we've talked about mechanism, but the stakes are worth naming directly. Stroke happens when blood flow to part of the brain is interrupted, either because a vessel becomes blocked or because a vessel ruptures. The brain is remarkably intolerant of interrupted blood flow. Brain tissue begins to die within minutes of losing its blood supply, and every additional minute without treatment increases the extent of permanent damage. This is why you'll often hear the phrase, "time is brain," in stroke medicine. And it's also why organizations promoting stroke awareness emphasize recognizing symptoms immediately. Things like sudden facial drooping, arm weakness, and difficulty speaking, and calling for emergency help right away rather than waiting to see if symptoms pass. What we've been discussing today sits earlier in that timeline, well before any emergency. The small blood vessels deep within the brain, the ones responsible for supplying specific functional regions, rely on adequate perfusion pressure to do their job continuously, day and night, for decades. When that pressure margin becomes chronically thin, whether because of an unusually low diastolic number in a person with stiffened arteries, or because of a widening pulse pressure reflecting significant arterial aging, those small vessels are operating with less of a safety buffer than they should have. This doesn't mean a stroke is inevitable, and I don't want to leave you with that impression. It means the risk landscape has shifted in a direction worth knowing about and worth discussing with your physician, ideally well before any acute event occurs. It's also worth mentioning that not every warning sign arrives as a full stroke. Some people experience what's called a transient ischemic attack, sometimes referred to as a mini-stroke, where blood flow to part of the brain is briefly interrupted and then restores itself, often within minutes, with symptoms that resolve completely. It's tempting to dismiss an event like this because it passes on its own, but medically, it should be taken as seriously as a genuine warning shot. Research on this topic consistently shows that a meaningful proportion of people who experience a transient event and don't seek evaluation go on to have a full stroke within a relatively short window afterward, often within the following weeks. If you or someone you love experiences even a brief episode of numbness, weakness, vision change, or difficulty speaking, treat it as urgent, and seeking prompt medical evaluation is one of the most protective decisions you can make, even if the symptoms have already resolved by the time you're being seen. Before we get to your action plan, I want to spend a few minutes on something equally important, which is what actually influences arterial stiffness in the first place, because understanding the causes gives you real leverage, not just awareness. Arterial stiffening isn't purely a matter of birthdays passing. Age is certainly the biggest single factor, since the gradual breakdown of elastin and buildup of collagen and calcium in the vessel wall is, to some degree, an inevitable part of getting older. But the pace at which this happens varies enormously from person to person, and a good portion of that variation comes down to things you actually have some influence over. Chronic high sodium intake is one of the more significant contributors. Excess salt causes the body to retain more fluid, which increases the volume of blood your arteries have to manage on a daily basis. And over years, that extra volume load contributes to wear on the vessel wall. Most nutrition guidelines suggest keeping sodium intake under roughly 2 to 3 grams a day. And the tricky part is that the majority of sodium in a typical diet doesn't come from the salt shaker at the table. It comes from processed foods, canned soups, deli meats, packaged snacks, and restaurant meals where sodium is used heavily as a preservative and flavor enhancer. Reading nutrition labels and cooking more meals from whole ingredients at home is one of the most effective, low-cost ways to reduce this burden over time. Chronic inflammation is another contributor that doesn't get talked about enough outside of medical circles. Ongoing low-grade inflammation, whether from untreated gum disease, poorly controlled blood sugar, excess visceral fat around the abdomen, or certain chronic conditions, appears to accelerate the same processes that stiffen arterial walls. This is part of why habits like regular dental care, maintaining a healthy waist circumference, and managing blood sugar aren't just generally good advice. They connect directly back to the mechanism we've been discussing. Physical activity plays a genuinely protective role here, and the encouraging part is that it doesn't require anything extreme. Regular moderate aerobic activity, the kind that raises your heart rate for a sustained period, whether that's brisk walking, swimming, cycling, or dancing, has been consistently associated with better arterial elasticity over time. Even modest amounts, something like 20 to 30 minutes most days of the week, appear to make a measurable difference. The mechanism seems to involve improved function of the inner lining of the blood vessels, called the endothelium, which plays a role in how well vessels can relax and respond to changes in blood flow. Sleep quality matters more than most people expect as well. Poor sleep, and in particular untreated sleep apnea, has been linked to higher blood pressure variability and greater cardiovascular strain over time. If you or a partner has noticed loud snoring, gasping during sleep, or persistent daytime fatigue despite what seems like adequate time in bed, it's worth raising with your physician, since treating sleep apnea can meaningfully improve blood pressure patterns, including the overnight patterns we discussed earlier. Chronic stress deserves a mention too, not because a single stressful day will damage your arteries, but because sustained, unmanaged stress keeps stress hormones like cortisol elevated over long periods, and this appears to contribute to both blood pressure elevation and, over time, vascular wear. This doesn't mean you need to eliminate stress from your life, which isn't realistic for anyone. It means that finding some regular practice that reliably brings your nervous system back down, whether that's time outdoors, a hobby that fully absorbs your attention, time with people you trust, or a structured practice like meditation or breathing exercises, is doing more for your arteries than it might seem on the surface. And then there's alcohol and tobacco, which I'll mention briefly because their effects here are well established. Tobacco use directly damages the lining of blood vessels and accelerates arterial stiffening substantially. And quitting, even later in life, produces measurable cardiovascular benefit within a relatively short period. Alcohol, particularly in larger quantities, is associated with higher blood pressure and greater variability in readings. And if you drink, keeping intake modest is generally the more protective choice. None of these factors act alone, and none of them guarantee an outcome in either direction. But together, they explain why two people of the same age can have meaningfully different arterial health, and why the choices available to you today still matter, even if you're 70 or 80. This is genuinely encouraging news because it means the trajectory isn't fixed. Consistent, modest changes sustained over months and years can measurably influence how your arteries age. I also want to briefly address something people often ask, which is whether home readings that vary somewhat from day to day are something to worry about. Some day-to-day variation is completely normal and expected. Blood pressure isn't a fixed number, it's a dynamic measurement that responds to sleep quality, stress, hydration, recent activity, and even the weather. What matters far more than any single day's fluctuation is the average over a week or two, and whether that average is stable, i.e. rising, or falling over the following months. If you find yourself getting anxious about a single elevated reading, it can help to simply take a second reading a few minutes later under calm conditions, rather than fixating on the first number. One more practical note worth mentioning. Try to measure at a consistent time each day, ideally in the morning before medication, and try to use the same arm consistently, since readings can differ slightly between your left and right arm. If you ever notice a meaningful and persistent difference between your two arms, more than about 10 to 15 points, that's actually worth mentioning to your physician directly, since it can occasionally point to a narrowing in one of the arteries supplying that arm. Let's bring this back to something practical and personal, because I don't want this to be an abstract lecture about arterial physiology. I want you to actually walk away from this video with a plan. Tonight or tomorrow, if you don't already own one, consider picking up a validated upper arm blood pressure monitor. It's a modest investment that gives you information no single office visit can replicate. Starting this week, take 2 morning readings, a minute apart, under the conditions I described. Feet flat, back supported, arm at heart level, 5 minutes of quiet beforehand, no talking during the measurement. Write both numbers down every day for 2 weeks. At the end of that period, calculate your average pulse pressure and take an honest look at whether your diastolic number is sitting persistently below 60, or whether it's been quietly trending upward over recent months. Bring that record to your next appointment, along with the 3 questions we discussed, and don't let the conversation end with a single reassuring word if your own data suggests there's more to discuss. If you happen to fall into one of the 3 groups we talked about, adults over 75, people managing diabetes or kidney disease or anyone on multiple blood pressure medications, it's worth being especially deliberate about asking whether your individual target has actually been discussed and set intentionally rather than defaulting to a generic number. And if your daytime diastolic tends to run on the low side, it's reasonable to ask about how your medications are timed across the day and whether a 24-hour monitoring period might be useful to understand what's happening overnight when you're least able to notice it yourself. None of this is meant to replace your relationship with your own physician, and it certainly isn't meant to create anxiety over numbers that, for most people, are perfectly normal and nothing to worry about. It's meant to give you the context that a 15-minute appointment often doesn't have time to provide, so that when you do sit down with your doctor, you're having a fuller, more informed conversation rather than accepting a single word as the entire picture. Blood pressure has always been reported as two numbers for a reason. They tell different parts of the same story, and after 60, the story that number on the bottom is telling deserves just as much attention as the one on top. If this helped you understand something about your own readings that you hadn't considered before, share it with someone in your life who's over 60 and manages their blood pressure, whether that's a parent, a spouse, or a friend. A conversation before the next appointment, armed with the right questions, can genuinely make a difference in how that visit goes. This video is intended for general education and isn't a substitute for personalized medical advice. Please talk with your own physician about your specific health situation, your history, and your individual targets. Take care of yourself, and I'll see you in the next one.